welcome to the third and last session. I'm Tom Phillipson. I'm an economist at the University of Chicago, also involved with a lot of work with medical innovation. I wanted to start up this panel by talking about two offerings that I think crystallizes some of the issues here, and then I'm going to introduce what it looks like a really fabulous panel to discuss sort of value-based pricing in this area. So the first offering I wanted to offer you is that suppose I gave you a complimentary dinner. I'm not included in the dinner because then you're going to value it a lot less. So basically, I give you a dinner every month for your family going forward in perpetuity. The only catch with this offering is that in order for you to get the dinner every month, we're going to have to infect you with hepatitis C, so a blood transfusion or something like that. Most people will view that offering as very crazy. They wouldn't sign up. Implicitly, what you've done when you say, no, I'm not interested, is to say that Sovaldi's price is okay. So why is that? Essentially, let's say we have a $300 dinner for your family every month, and we were to amortize that over time in perpetuity, we would get the price roughly of Sovaldi, ballparkish. So the issue with Sovaldi is much more about payments occurring at a particular point in time, in particular for cures, where the cost is upfront for lifelong benefits. Essentially, you have this issue where you have initial expenses that are high that needs to be borne as opposed to paid over time. So in other areas where we have this case of upfront costs for longer benefits, we have credit markets. And that's what the interest rate is, or the dinner payment is an interest rate essentially reversed. So, for example, we wouldn't have as much housing construction if we didn't have mortgages. If you have to pay $1 million for your house up front, very few people could probably do that. Or if you're sending your kid to college and they couldn't take out student loans, they probably wouldn't go to college, some of them, because of the upfront cost of the universities are so high. So the issue is really not so much about cost versus benefits, it's that the costs are front-loaded for medical cures, and the benefits are lifelong. And then the question is, how do we arrange better credit markets? And we'll be talking about that partly in this session. But the price per pill is completely irrelevant. Ideally, we want one pill for 86 grand rather than 90 pills for 86 grand. Why would you want to take a bunch of pills? So the price per pill is completely irrelevant to that discussion of the value of the benefit over time relative to the cost of the benefit over time. The second offering I'm going to offer you to illustrate some of the sort of profits, the mechanics of the profits of medical R&D, which are very poorly understood, I think, in the health policy community, is to offer you a lottery where you're going to pay $100 to participate in this lottery. And if you win, I'm going to pay you $1. You say, what are you talking about? That's crazy. Or I have another lottery where if you win, you get paid $100. You still think I'm crazy. Why would I pay a lottery ticket for $100 to win $1 or $100 if there's a possibility of losing? But that's really the medical R&D process. So suppose the ticket price is the R&D price of developing the compound of $100 million instead of $100. The $1 is the production cost if you actually go out and sell the compound, actually producing the pills. Many times a small fraction of the R&D costs. So if you only had the firm earning the production costs, $1 for putting down $100 up front, clearly they couldn't make back the $100. And that's the problem with profits being higher, sales being higher than production costs of pills are kind of irrelevant for the overall profitability. But even if you pay them the R&D cost, that is to say, you got a lottery ticket, which lost a lot of times, but when you won $100. You still, you're not making money. You're losing because every time you didn't win, you lost $100. So that would be, if we look at, like some people in the health policy community do, R&D costs compared to profits when you go to market. That's a misleading statistic as well for the same reason. In fact, if you have 90% chance of failing going to market, which is roughly what FDA provides you with, you must have at least 10 times the profitability over the R&D costs going forward to make up that 90% chance of losing. Okay, so profits must be higher, much higher than R&D costs once you actually have a successful compound to break even. Those mechanics, I think, are very poorly understood. Both the production cost being covered by sales is not an indication of anything of profitability, overall profitability. But even when R&D costs are covered by sales, it's not an indication at all about overall profitability of the portfolio you're investing in. So I think that's important to keep in mind, because most evidence against pharma is really about, you guys are so profitable. That's really the underlying, I think the underlying gist here is like, you guys are really profitable. Shouldn't you make less money? And that's the metrics that are kind of used in that discussion, which misses, I think, the overall mechanics of doing risky development. So I hope we keep those keep that mechanic going forward in mind when we have our discussion today. Today we have a really interesting panel, and we're going to generally talk about pay for performance, if you want, in drug development or in drug medical product development. We're going to have Greg Daniel opening up with a talk, and then we're going to have a panel of 3 people representing payers and also, I guess, the patent community and the generics patent community. The first panel member is Andrew Allison. He used to be the Medicaid director of Arkansas from 2011 to 2004. He was also the founding board president for the National Association of Medicaid Directors and served in that position from 2010 to 2012. The second member is Al Engelberg, who should be very familiar to those people who work here. He's also the founder of the Engelberg Center for Health Reform here at Brookings. He is initially an intellectual property lawyer, and I actually learned that he worked at the patent examiner office for 40 years. Is that correct?
That was 40 years ago.
40 years. Oh, I was wondering, are we paying our public employees too much? Yeah. Okay, so it says 40 years. Okay, for more than 40 years, it says it. Okay. He's also on the board of trustees since 2007, and like I said, has been a counsel working for the generic drug industry in a big part of his life. The third member is Chris Collar, who is the president of the Milbank Memorial Fund, and also before joining the fund, he was the Rhode Island's first health insurance commissioner, so we get 2 payer perspectives on the panel. He's also currently an adjunct professor in community health in the School of Public Health at Brown University. But first we'll have Greg Daniel sort of lead in with a talk, and then we'll have panel members come up here for a more general discussion around those issues.
Thanks, Tom. So I want to pick up on one theme that we heard, I think, recurring throughout the earlier sessions today, and it was something that Dana first brought up, which was the question that we should be paying for value. And I would modify that to say we should pay for value when we see it. I think some of the challenges that we've had in the healthcare setting is that the delivery system, the incentives that are in place for providers and payers and others within the healthcare setting aren't well aligned with making sure that we're maximizing the value of the healthcare that we're delivering. I think we're making a lot of progress, ACOs, bundled payments, a lot of effort right now in payment reform, but to Sam's point, this has largely been outside of the scope of pharmaceuticals. So that's the one theme that I'd like to pick up on this particular talk. And also I'd like to raise or at least broaden the discussion a bit away from Sovaldi, but thinking about more of the general class of breakthrough therapies that are increasingly complex, targeted, and are coming at higher costs. So before I get into the actual payment reform ideas, I just want to provide some context. As we've all heard and know as a fact that the scientific advances in genomics, proteomics, better understanding of diseases in the body are leading to great innovations and great breakthrough therapies that are fundamentally changing the way we treat therapies. Looking at data from a publication from Lanthier et al. From FDA, he sort of looked at the number of new medical entities approved each year. And the red bar shows that, unfortunately, this graph stops in 2011, but you can see from sort of 2009 to 2011 that there's been a significant uptick in the red bar in terms of drugs that are approved that are first in class. And first in class is a relatively crude measure of the potential of a product. So if it's first in class, generally it's thought that this might be a potential game-changing therapy. So extending that to what we see today, just last year, we saw about 33% of the approvals from CDER have been first in class. And it's estimated that the drugs that are not yet approved but are in the pipeline, approximately 70% of those are expected to be first in class. Oncology is an interesting example too. In that field, we're seeing more and more targeted therapies. Targeted therapies are increasingly being used. They're coming at very high costs, and they're being used in very narrow indications, very small patient populations. In 2003, we saw the green bar, about 11% of the drugs used in oncology were considered targeted therapies. To just last year, was almost 46% of all of the drugs in oncology are targeted for particular genetic makeups of tumors, and we're definitely going to see that trend more and more. Also, a recent analysis by Evaluate Pharma looked at the top 100 selling drugs in 2010 and then again in 2014 and saw some substantial differences occurring. The first is the median cost for treating a patient for a year for anyone who was taking at least one of those top 100 drugs. In 2010, the median cost was about $1,200 a year, which increased to about $9,400 in 2014. Of course, there's cost of living increases and all of that. But what was particularly interesting is the total population served by any one particular drug in the top 100 went from 690,000 all the way down to 146,000. So this trend is increasingly complex and expensive drugs, but that are treating much smaller and smaller patient populations. Sovaldi is an exception here, where obviously, as we talked before, this is not as much of a rare condition as what's being demonstrated in these slides. So I'd like to turn to other reforms that have been happening in parallel to all of this, and there has been an increasingly large amount of effort over the last 5 years at looking at the drug development process, from clinical drug development, the tools that FDA has to review and approve drugs. And there have been a lot of substantial changes, one of which was the FDA Safety and Innovation Act of 2012. That did a lot of things to help improve and make more efficient the innovation process. For example, the accelerated approval within that legislation was made more flexible, allows FDA to use broader sources of data and to use accelerated approval in more instances when it's appropriate. Also, the breakthrough therapy designation, as we know, as we talked about this morning with Sovaldi, that designation came out in that legislation and was spearheaded by Brookings and Friends of Cancer Research. And that really does look at very early on in clinical development, very early phases of development, for drugs that show substantial promise and are demonstrating substantial promise with clinical data. It allows the agency and the sponsor to work much more much closer together in order to think about innovative ways to expedite drug development. So if this is a promising therapy, how can we get it through the regulatory process much quicker and enable earlier access to patients? So accelerated approval can be useful in that too. And also what's useful in that's not necessarily a reform, but a big trend that we're seeing in clinical trials themselves. They're becoming increasingly adaptive, using initial analyses to better target particular drugs to patient populations, master protocols that can make more efficient the enrollment process for clinical trials. And all of these are intended to say, okay, if we have these promising therapies, how can we get through the regulatory process much quicker, still generating the evidence that we need to meet the standard evidentiary criteria for regulation, but that the effort is getting these increasingly complex and promising innovative therapies to patients quicker. So progress in these biomedical sciences and in the clinical development as well as regulatory sciences are allowing earlier access to patients for these therapies. And they are coming at substantially higher prices, and I think we all have agreed that they should, that we should pay for more for drugs that are actually resulting in either cures or substantial increases in quality of life for patients. But it does create this conundrum, which is, how do we control costs but also have the right economic incentives to reward for innovation? Because we don't want to create a situation that decreases the incentives or the activity in really coming up with discovering and developing therapies that could be curative or are really addressing unmet need and aren't these incremental changes that we see in some of the Me Too additions to class. So the question that I'm sort of interested in is what are some potential models for improving health, incentivizing the development of these game-changing therapies, but also in a way that is safeguarding future innovation. So providing the rewards for manufacturers while we're still addressing the total cost of healthcare. So looking at more innovative ways to not, as we spoke this morning, I think everybody also agrees we shouldn't just look at the price of the drug itself, but what impact it has on a total population of patients and the impact it has on the cost of care for that particular patient. So there are a couple things that we can do to look at all of these issues. Direct price controls is one thing, and that's, by itself is probably not a great idea if that results in fewer incentives for manufacturers to innovate. Major patent reform can also be combined, and I think Al is going to speak a little bit about that. Payment and delivery reforms that drive value, that's going to be the basis of the rest of my talk, and then novel financing mechanisms that Tom alluded to, I think will also speak to that as well. So the last two items are really the focus of myself and Tom on this. So one of the ways to do this is to drive toward realizing better value in healthcare is to tie reimbursement to actual real-world evidence development. Clinical trials are great, and they tell us a lot that FDA needs to know in order to approve the drug. They really tell us the potential of the drug in the sort of controlled laboratory-like setting. What is the potential of this particular drug to bring to really improve patient outcomes? But the reality is, in clinical practice, we rarely see the full maximum potential for that particular drug. So we need to look at the setting and say, why is that? Why aren't we really maximizing the value that these drugs could potentially bring? And one of the things that can help us do that is to collect evidence on the product while it's being used in clinical practice. Coverage with evidence development has been a tool that's been used rarely, but has been used by payers, largely CMS, but also private payers, to say, okay, well, there's a promising therapy on the market. Let's provisionally cover that as long as the patients who are getting that and the providers who are using that are contributing data to a registry so that we can continue to monitor the use of that product, learn how the product does bring value, get a better understanding of the right patient populations that product can be used, and really inform how the drugs are used in practice. It has been used rarely, and I have on the next slide some challenges to that, but it could be a potential model for specialty drugs. Largely it's been used for medical devices, but the concept for specialty drugs is interesting. It doesn't necessarily have to be provisional, but is there a way that we can tie payment for a particular drug to ensure that the providers and the healthcare system as a whole is contributing to the development of better evidence on how to use these products? It's worthwhile, and it's only worthwhile if the evidence that data can bring really outweighs the costs for doing the research and collecting the data. But there are some feasible steps that we can do to make that more efficient. For example, the increasing use of claims data, electronic health record data that are routinely generated as part of routine care Those are being increasingly used to generate medical evidence and to better understand how these products are being used in the population. Reduce costs for prospective data collection. PCORI is developing a new PCORnet system that's bringing together clinical data and patient-reported data that could be used to do more efficient randomized studies in the post-market setting. So there are a lot of opportunities. We're not there yet, but there are opportunities to think about how we might make evidence generation in the post-market setting more worthwhile as something that we can do more often and potentially tie to payment for a particular drug. As Kavita mentioned, there are also some payment reforms from the provider perspective that are happening right now. Bundled payments that are tied to performance measures. So you have the providers have incentives to increase quality of care because there are performance measures to report on. But with the bundling of the payment, there's also an incentive to make sure overall treatment costs are low. ASCO, United Healthcare, and others have looked at, and particularly in the space of oncology, for patient per member per month payments for drug administration and other services. The point here is to de-link the clinician revenues from volume and intensity of the particular drug use. Peter Bach and others, as well as other folks outside of that group, have proposed single bundled payments for cancer chemotherapy to include supportive care chemotherapy, so an entire bundle that's just used to manage the drug portion of treating patients, and that could be useful. It would only cover drugs that are covered in the medical benefit. But for pharmacy benefit drugs, those have been challenging to think about how we might finance those in a bundled payment mechanism. But there are existing reforms that are becoming increasingly more prevalent that can help. Medical homes, accountable care models, where the entire spend from a provider community or from a set of providers is dependent upon use in both the medical setting and in the pharmacy setting, particularly for managed Medicare and private plans. So while not directly tied to the actual drug itself, it does improve the ability for providers to they get paid more for better management of the particular patient population as well as management of costs. There's some benefits to doing, as I articulated, to bundled payments. For example, increasing quality and decreasing costs would be the encouragement to providers. There are also stronger incentives to manufacturers. Potentially the question is, within ACOs and within these new sort of medical home type accountable care models, what's the role of the manufacturer beyond just developing and selling a drug? Manufacturers know probably the best about how to best manage that particular therapy within the intended patient population. So disease management tools, adherence programs, additional tools to help providers and ACOs to manage that particular patient population, identify the right patient population that would best respond, and then help deliver on those outcomes. There's a lot of challenges, though, obviously, with bundled payments. One of the biggest is that it has been shown to sort of discourage use of new therapies. So if a bundle does not include the price of the particular new drug that's on the market, provider systems and hospitals would be incentivized not to use that particular therapy. But NTAP and other sort of risk adjustment type models can be one way if awarded by CMS to pay for the excess cost of the new therapy, but if it's valuable enough, the provider can choose to use that. So the last sort of item beyond sort of tying it to evidence generation or bundled payments is the concept that we've seen very rarely again in the outpatient setting, sort of performance-based outcomes for drugs. So the idea is to tie the actual purchasing contract for the drug, and this mainly has been used in the outpatient setting, to the actual performance, either performance or outcomes that the drug achieves. So in that case, the manufacturer shares and bears some of the risk for the performance of the drug. So if the drug fails, whether it's because of lack of adherence or full adherence, but the intended outcomes aren't achieved, then the manufacturer bears some of that cost through rebates, discounts, or other financial payment back to the payer for purchasing that drug. It's been very challenging to implement these in reality. There have been a lot of challenges with government price calculations, with just the sheer cost of collecting the data, the challenge of actually what are the right outcomes measures, what are the performance measures that we want to base these contracts on. All of those have been challenging. But I would say that now might be the time to think through, okay, why have they been challenging? Are there ways to make these work? Because the concept seems right. They haven't worked in practice, but with the increasingly targeted, curative, very high-cost drugs, I think as a healthcare community, we're going to have to come together and figure out how to make something like this work, or some additional payment reforms that can really bring drugs into the new age of health reform, which is paying for better outcomes at lower costs and increasing quality and care. That's it. Thank you.
Does this work? Good.
Okay, so here's what I suggest. You can probably hear me. Why don't we start with Al, who's mic'd up already, and we'll go towards me instead. So Al, go ahead. We have about 5 minutes each for people on the panel.
So I'm an intellectual property lawyer and have been engaged in for about 30 years, to clear up Tom's confusion, in the generic drug industry, starting with representing the generic drug industry and drafting the patent and exclusivity provisions of the Hatch-Waxman Act. And my thesis here is that we're actually overpaying for drugs, and the reasons we're overpaying for drugs relate directly to the government's policies. We have monopoly incentives that no other industry enjoys, that turn out to be too rich and are not specifically well targeted. But we also have a bigger problem, and that is that the government is getting really no return on its research investment. And I think if we examine those two areas, which I'll try to go into in a little bit of detail, we could get to faster cures and pay less for drugs. Many panelists talked about the need for incentives and the short time that drug companies have to make a return and the high cost of development, but nobody talked at all about how well the pharmaceutical industry is doing, and I just want to take a moment to point that out. In 1984, when Hatch-Waxman first created generic competition, the market caps of Merck and Pfizer, adjusted for inflation to 2014 dollars, would have been about $14 billion. Today, they're at $175 billion, more than a 1,200% increase. Sales of branded pharmaceuticals have also risen more than tenfold, from about $23 billion in 1984, adjusted for inflation, to about $250 billion today. And in fact, they would be closer to $800 billion a year were it not for the fact that we created generic competition, because 84% of all prescriptions are now being filled with generic drugs, and last year generic sales were $90 billion. If that $90 billion had been branded sales, we would be looking at an additional $400 or $500 billion. More significantly, the annual return, annual profitability and return on equity in the pharmaceutical industry for several decades now has been in the high teens to 20%. It's at the high end of all industry sectors in terms of profitability. And that leads me directly to the first of the monopoly questions, and that is that the government needs to take a really hard look at the $30 billion a year it's spending in R&D. Under the current legal regime, the Bayh-Dole Act of 1980, the title to all of the intellectual property developed with government funds belongs to the universities where that intellectual property was developed. Those universities, in turn, are earning about $2 billion a year in royalty income, plus equity interests in a lot of startup companies by transferring that IP to big pharma. Now, that's not a bad thing, and taken at one level, but the reality is that big pharma, in turn, has been shrinking its investment in R&D, and academia is now becoming the principal driver of drug discovery, and the essentially the research department of the big pharma companies. And in return for that, the government gets nothing. 35 years ago, when Bayh-Dole was enacted, academic research was really focused more on physiological processes and not on product development. Today, every academic medical center has a division of translational medicine and is, in the world of genomic science, is moving directly from to finding targets and developing products. It strikes me that it's time to relook at that whole balance and determine some way that the government and the public, which is paying for that research, gets a reasonable return. Most regulated industries, utilities and other industries in our country, earn single-digit returns. Sam Nussbaum talked about very low single-digit returns for Medicaid providers. We have a public-private partnership today in which the public pays and the private part takes and is making an 18-19% return. That translates to 30-40 billion. On the question of the exclusivities, the theory of Hatch-Waxman was that providing longer exclusivities for pharmaceuticals would incentivize greater and faster innovation. The fact is, and there's 30 years of data to prove this, that what it actually incentivized is more patents for every product, and the development of something called product lifecycle management, in which more money was spent figuring out ways to reformulate products and to patent minor advances than to do real value-added research. And part of that is because every patent gets the same extension regardless of whether it's a meritorious patent or not. The end result of those 30 years has been, and most of you are aware of this and followed the Supreme Court discussion of reverse payments, we developed a litigation industry alongside the patent extension industry, in which generic drug companies were encouraged to sue to break the bad patents, ended up making settlements with the pharma companies to essentially share a portion of the profits, monopoly profits, by taking a payment rather than going on the market. And many of our most successful generic companies over the last 15 years have made as much money from patent litigation as they have from manufacturing and selling drugs. We didn't learn from that experience. We have compounded the problem in the Affordable Care Act by giving even more exclusivity to pharma companies. 12 years of non-patent-based exclusivity, meaning that we are now giving exclusivity to products that are not even sufficiently new to qualify for a patent, and also a new set of rules making it far more difficult to challenge whether or not these biologic patents are valid. And so we have now come to the end of the generic drug era. There is not going to be a meaningful generic biologics industry because the drugs are not interchangeable, and the length of exclusivity is far too long. I've always said, I wrote this 15 years ago, that there is no greater incentive to innovation than the looming expiration of a patent on a profitable product. And we seem to have missed that message in government policy and need to move toward a system not where we abandon incentives and abandon exclusivity entirely, but where we limit those kinds of extra bonuses as incentives for only true value-added invention, and to determine that at the time drugs are approved. The end result, I believe, would be that we would stop paying as much as we are for minor improvements, get better value added, and be in a better position to pay the cost of breakthroughs.
Chris?
If it's okay with you, I think Andy and I will switch.
Terrific, actually. If that's all right, I think Chris and I talked, and what I'm going to want to speak to as a former Medicaid director in a couple of different states, and actually start off here in town. The first job I had at the Office of Management and Budget, one of the first assignments was to help finish the first regulation implementing the drug rebate arrangement, the payment scheme for Medicaid for drugs in this country, which has now been in place for nearly 25 years. And just so everyone in the audience understands how it works, it's essentially the Medicaid program at the federal level Congress chose to use sort of the buying leverage of the Medicaid program collectively to negotiate a price which is pegged to a percentage of sort of an average competitive price on the private market, which I'll get back to. And this, using this leverage to try to strike some balance between access and price. And the deal was if the states would actually have to buy all drugs and not be able to exclude them through formulary if they accepted, and Congress mandated that they accept the rebates. On average, that balance might work to sort of make sure that the price that the public is paying for publicly insured individuals is tied down and is pegged to, as John described, a 21% discount against sort of the average price that the manufacturers would charge to private payers. I want to address the question of whether it actually ties down the price and just point out that if the Medicaid share of the disease burden is big enough, the tail will wag the dog. And instead of there being some naturally occurring price tied to value somehow on the private side, and then Medicaid paying a discount of that using its leverage, it could be that the manufacturer, if that Medicaid buy is going to be big enough, and I'll get back to that, would care less about the private market and more about the Medicaid market, or, as John's described, the markets in other countries if pricing is really through some waterfall effect, income proportional, to GDP, et cetera, per person GDP in another country. So, for example, in the case of Sovaldi, and you saw a pie chart earlier sort of depicting Medicaid's share of the Sovaldi buy, and gosh, even in a small state like Arkansas, that's $500 million, which is a tenth of our Medicaid purchase for, one disease, for a fairly small percentage of our recipients. That pie chart, I would suggest to you, might understate the public purchase. If states are effective in expanding their Medicaid program and drawing in the uninsured, if states are effective in rebalancing the mix of how much prisons are paying for drugs as opposed to the Medicaid program, I won't get into why that shift might occur in reality. Medicaid's share might not just be the small blue triangle that you're looking at. It might be a quarter, it might be a third, it might be a half. And you can easily imagine with targeted drugs, as we've heard about, that manufacturers might find a case in which the public purchase, which is pegged to some sort of private price, is actually a majority or even a supermajority of the purchase, especially if the incidence of the disease, like Hep C, is highly correlated with eligibility for the public program, which in Medicaid's case covers the low-income individuals. So depending on their age, depending on their disability, you're looking at a mix of Medicaid and Medicare. Bottom line, what's really driving the price in this case? John described it as a choice. John described it as a choice by the manufacturer, not the result of an interaction in a private transaction here. That's not what's setting the price. What might we suggest is really setting the price for Sovaldi? Maybe the market isn't, between John and Sam. Maybe the real market is in this room and on the front pages of the paper. That's really the brakes on pricing, because in a purely rational sense, if there was no press coverage, if there was no backlash, and if that didn't, I assume, carry some sort of economic cost to the firm, that ultimately we wouldn't see a $80,000 or $90,000 cost. We'd likely see a $200,000 or $300,000 cost, potentially driving a lot of private purchasers out of the market, but enabling the manufacturer to make it all up and more with the guaranteed Medicaid buy. I think what Sovaldi is revealing here is the fact that public purchasers are right now susceptible to exactly that circumstance. If Sovaldi isn't it, it's going to be one of the next ones. Leaving us the question, well, how do we value this? If you really can't rely on a private transaction to drive it, because that transaction itself is so highly distorted, it's not even pure monopolistic price discrimination anymore. It's being driven by formulaic reference to another large purchaser. Well, we've had the conversation here. What can we rely on? Total cost of care. Arkansas implemented, I think, one of the more innovative payment reforms in the country related to total cost of care for patient-centered medical homes. Theoretically, if the total costs were appropriately set, the physician at the heart of that decision-making would have, in Arkansas's case, a very strong financial incentive to trade off the new drug against existing therapies. But the whole process breaks down if the total costs were pegged to a historic purchase of X quality-adjusted life years of health, when what Sovaldi is doing is adding to X. We are now buying more in healthcare. How do you value the additional life years that the drug clearly provides? You can't trade that off against necessarily the cost of the old, ineffective, and poorly adhered to intervention. You have to adjust the total cost of care. And how much do you add to the payment to WellPoint in a managed care state for Medicaid for Sovaldi? Answer, there's nothing inherently in the transactions that occur now tying that price down. And if Medicaid's a big enough, or the public is a big enough share of the pie, it amounts to a public policy decision. We have to have the adult conversation. And eventually, the value that you attach to the price is not the value of alternative therapies, it's the value of the life itself. And eventually, we will have to come back to that if the next drugs are effective.
That's a heck of a place to leave it, Andy, so I'm not sure I'll follow up. So I want to thank Brookings and USC for the chance to have this important conversation. And it's not just about Sovaldi, it's about high-cost innovations. I come at this from the perspective of the fund, which works a lot with states to give them evidence to improve population health, and also, as was stated previously, as a state official. What I want to serve my first report from the states, so we just worked with our colleague, the Center for Evidence-Based Policy, to look at what are the state coverage policies. Dana is absolutely right. His elegant cost-benefit analysis notwithstanding, Medicaid agencies are going for that, the most acute 5%. They are unpersuaded by your long-term payback. They just have to, frankly, do triage to make sure that what's defined as the most deserving, which are the most acutely ill patients, get this first of all and hope for some sort of price relief. So the kinds of things that they're putting in place are limiting the benefit to once during the patient's, the beneficiary's enrollment in Medicaid, having a severity requirement, requiring a response to the therapy, requiring coverage with evidence, or having requirements around who prescribes, and or some sort of controlling, as was stated earlier, around history of substance abuse. I also want to underscore what Sam is saying, that the state actions are not limited to Medicaid. We just did a briefing for budget officers where they wanted to understand what the cost impacts were, because this is totally unexpected for them, and it is significant in a percentage basis. And particularly in states with aggressive rate review, there are significant pressures that are being pushed on insurers for the fully insured market, so they simply can't pass those costs on to the employers. With that sort of setting, what are the kinds of things that short term you could think of, both on the price and on the utilization side, around these high cost drugs? One is I think we need to keep looking at the approval process to make sure that we are not jeopardizing patient safety in our rush to speed innovations. We want to make sure that there are sufficient trials that are going through, that we have not compromised that. And there are some concerns, at least raised by Medicaid officials, around the speed with which the process is working. I think, secondly, as was mentioned a couple times, post-approval evidence collection needs to continue in a controlled basis. The idea of coverage with evidence is certainly something that needs to be pursued more aggressively. Sometimes states put in place commercial benefit mandates, for instance, in cancer drugs, that limit the ability of insurers to negotiate around these innovative drugs. So you've lost your leverage if the manufacturer knows that you have to carry their drug regardless. And then fourth, as has been pointed out in other settings, there's no guidance coming from the FDA around the class of drugs called biosimilars. So not generically identical, but that have the same effect, that can be fraught, but it's something that needs to be pursued. Thinking more long term, I just want to throw out sort of some big thoughts and some small thoughts around what can be done. If the hallmarks of an innovative breakthrough drug are that it brings significant benefit, that it's clearly better than the alternatives that are out there, and that it has this long payback period. Those are what we've heard today, those three things. It really affects quality of life. It's better than anything else out there, and it has a long payback period. What I think we need to realize is that these decisions are being made in the reality of a constrained budget. Whether it is a managed care company or more fundamentally, state budgets. It also happens with Medicare too. And so we have to get to the language of trade-offs, as awkward as that might be. And those trade-offs don't happen within biomedical innovations. Those are trade-offs around the inefficient medical treatments that was talked about in the first setting, but also we've got trade-offs with things that we know deliver innovation, that are innovations but are not biomedical innovations. If you're looking at long-term payback, early childhood is where it's at. It would. I don't have the numbers like Dana might, but it would blow away any sort of biomedical innovation in terms of what you can do for nurse-family partnerships, for early childhood reading. And if we're going to look at social value, we need to look at social value across all innovations, not just the biomedical ones. And what that leads to is, I think, again, thinking big, we have to get more comfortable with using cost-benefit analysis. That's implicit in some of what we're talking about. It's been explicitly removed from some other places of work, but we have to get more comfortable at these cost trade-offs because resources are limited. Now, to the task at hand, I think the things that, what I want to point out in terms of task at hand is the complete lack of policy coherence across the public payers for how we determine drug pricing. So while Medicaid works off of administered pricing in the way that Andy described, Part D leaves it to manufacturers to do. And Medicaid has tried to shade that difference by giving the drug benefit, in some cases, to managed care companies, which they then want to take back. So you have a complete lack of coherence around how the public purchasing decisions are being made. The second point is I think the ideas that Greg talked about make a lot of sense if you can lump drugs into something larger. I think that task becomes really hard if you're talking about something with a long payback. It's very hard to come up with a payment bundle that affects anybody other than the public at large if you're dealing with a 20-time return. So I think as I end up where Andy does, there is a public interest in the price that is set at the beginning. And I just want to compare two colleagues in state government facing coverage decisions or treatment decisions, policy decisions around interventions with a long-term benefit that is significant but takes a long while to come back. One is the Department of Health director who's trying to come up with vaccine policy, and the second is the Medicaid director who's trying to deal with these long payback, high-cost drugs. The public health director faces a very different decision because of the pricing policies that have been put in place around the role of CDC in assessing value over time for the vaccine. That's not something that we have allowed or developed as a public policy for these high-cost drugs, these biomedical interventions. And I think I end up where Andy does, which is that there's a public interest around this value determination. It's going to be difficult for Sam to do or for any individual participant. And I think we're going to end up at that place sooner or later. I actually think the ACA helps with that decision because we've put everybody in, so we're going to have to make these decisions collectively. So that's where I'll end. Thank you.
Okay, a couple of responses which comes up in all three discussions here concerns the rate of return on equity on pharmaceutical companies. So I agree with Al that a lot of work that generate these products comes from NIH funding at universities, essentially publicly funded research in the R&D part, the R part. However, most of the money that needs to be spent to bring it to market obviously comes from the development, the D part in R&D. And because that is so substantial, you're going to need investors. So usually professors are not motivated a lot by money. That's why we at University of Chicago and elsewhere don't pay them anything. So they will, they want Nobel Prizes. They want a bunch of other stuff than money. They want recognition mostly. But investors only care about one thing. They care about the risk and rate of return and the risk of that rate of return on their investments. And you need investors to go the D part in R&D. So here's the confusion that many times comes up, and I think it came up here on this panel too, which is clearly there's a positive relationship between risk and return in capital markets. So if you lend money to a company, you get paid a larger interest rate than if you lend to the government, because the government is not going to go bankrupt, we think, at least not yet. But a lot of companies do. So, lending money has more risk when you lend to the corporate bond rates are higher than treasury rates. It's a positive risk relationship between rate of returns and risk. For the same reason, equity returns in medical R&D is actually higher than other industries' returns. So the question is, people every day look at these returns and they're still not bidding up the prices for these companies holding these assets. There must be some kind of indication, if there's no free lunch in the capital market, which is unlikely, there must be that the risk of these investments are higher than in other sectors. So merely pointing that the rate of return on equity is high in a given industry misses completely the point that rate of returns really are compensations for the risk that you're holding. So investors are not stupid, or the capital market is not stupid. It's not that they're ignoring these high rate of returns. Why wouldn't everyone want high rate of returns on their investment? You want it in your pensions, and that's why the pension funds run Wall Street to get you higher rate of returns. So there must be some risk here in this sector that's not present in other sectors that's compensated for with these high rate of returns. And the major, I think, candidate for that risk is government risk. That is to say, this is a sector which is faced both in the approval process and also in the reimbursements with dramatic government risk. So we have no idea what the budget battles are going to be in 10 years from now when your product gets approved, if you're now developing it. in terms of Medicare reimbursement. So there's enormous price risk for your product in the future. And likewise, we have a lot of uncertainty in the FDA approval process, which is very hard to eliminate that risk in some sense. You can't study your way out of it. You can't study Congress to death and figure out what the risk is. So there's some compensation taking place in these rate of returns that the capital market is indicating is compensating for risk. So the arguments you hear here are misleading, I think. It ignores 200 years of capital market experience that we have higher returns for more risk. And we need to take that into account. That said, I wanted to get to the point that essentially this panel, I think, is very suited to address. This was alluded to in earlier, that this is not the highest priced drug we've seen, but the prevalence times the per capita cost are very, very high in this case. And I want to bring to the panel, what do you think is going to be the future if we bring in extremely valuable therapies, and this is a real concern, I think, extremely valuable therapies for large populations. How will Medicare or Medicaid just cope with that without credit markets like I discussed? In general, how do you think what will happen if down the line in 5 or 10 years we have major improvements, let's say, in diabetes care or breakthrough things that can't we even think about today? 15 years it must be if it's a 10-year development process, because otherwise it would be in the pipeline. So basically, what do you think is going to be the reaction of the payer community to those kind of therapies in the future? I think that's what's at stake here. We sort of see this is the first time we get a high prevalence disease with high per capita costs, and it's sort of alluding to what might be coming in the future. I want to get your reaction, what you think, if this happened in 5 or 10 years, what do you think would be the response by the payers?
Tom, I might start just suggesting that you'd see a room a little bit larger than this if the prevalence was higher and the payoff was higher. And under the current pricing regime for Medicaid and public payers, if the incidence of the disease was like this one or even more skewed towards public financing of one kind or another, the only remedy that exists in the marketplace is the informal pricing pressure, not so much a change in mechanisms for how we pay for healthcare generally, or if the regime doesn't change, you'll just see a bigger room, and hopefully that has the effect of depressing price, with manufacturers in order to sustain it and not blow the budget. But until we address it with public policy, more of the same.
Well, I think we're already seeing it, Tom. If you look at Part D and private insurance, all the specialty drugs are in the 4th and 5th tier, and the cost is being shifted back to the individual who is faced with the disease, so what you're going to witness is more and more the breakdown of insurance. I mean, insurance systems only work if we share costs when it's reasonable. We don't share costs when it's unreasonable, and we're pushing insurance costs to a crisis point in the country. It might well be to the point we just made that pushing the price back to the public is maybe the way to go, because that will lead to the public outcry. The public outcry will lead, in turn, to corporate responsibility and a depression of the price. But I don't see any way out of the box. Government's not going to pay for it.
It would be an interesting question to see which would precipitate action quicker, a crisis in Medicaid or a crisis in the private market of the kind that Al's talking about, because you are seeing the creation of these 4th and 5th tiers, and there's a limit to what you can shift to individuals, and then they're going to push back, look for some sort of action.
I think we're gonna need to have a higher rate of return for the risk that's there in clinical development, as you point out. And I think we can do a lot to de-risk clinical development. Like I talked about, the breakthrough designation actually does provide some de-risking improvements to clinical trials and all that, but that can only go so far. So we're still going to need a large rate of return. And I think the question is not what are the payers going to do in 10 years. I think it's how can we start preparing now. And I think the biggest advantage is to eliminate waste and healthcare system. Sam provided a slide very briefly, a small percentage of the population that didn't complete therapy, but resulted in a large cost, and that bar was waste. And if we have programs in place, and if we think about the delivery of care, and I think we're getting there, like I said, with ACOs and other reforms, but we need to substantially do a better job at eliminating waste, because I think that's where we're then going to be able to afford the cures. Because you're right, I mean, how would you even price and value a cure for diabetes? So you give that to a patient that doesn't have diabetes yet, and how would we value that is an important question.
I think there's another question though in the research enterprise, and that is the way it's divided now. The public money and philanthropic money is the engine for the front end for discovery, really, and the government and perhaps philanthropic payers, which are a bigger segment, are going to have to move toward de-risking going forward by shifting some of this R&D money further down the line. Right now, all the public money's in the preclinical area, or almost all the money, and all the pharma money, basically, because it's in the back end, not only it controls the rate of what gets through, it controls the timing, which often is related to what products are already on the market and how fast someone wants to obsolete them. So I think the public-private partnership needs some shifts in it to take into account de-risking, and the government, for its part in de-risking, has to become a partner, not in a royalty sense, but in a sense of trading risk for price in this enterprise. We did it. It's not new, although we didn't get the benefit of it. We did it with AZT. The government did all the clinical work, recognized the need, it had the products, pushed it through. Unfortunately, it flubbed the intellectual property, and Burroughs Wellcome ended up with a high-priced drug, but it needn't have been that way.
Sure.
I want to go back to your first point, Tom, and the question of whether the point in this conversation is about the rate of return to equity and how uncertainty about that rate of return might be depressing capital investment. Are we not benefiting from new drugs today because of the uncertainty about rate of return? Ideally, the only uncertainty in that transaction is whether how effective the research process is and developing successful drugs. That's the risk, right? Or is an explanation for your observation that what we really face, or what manufacturers face, is the uncertainty about what the pricing regime actually is, and what the price will be, and what the rate of return, for an additional, quality adjusted life year is. My observation would be the real problem here is the distortion in the demand curve, not the fact that we have, patent protected monopolistic pricing. We know that. That's not foremost the issue to me. To me, the issue is we have so distorted the demand curve in healthcare of necessity, both because folks can't pay for it due to low income, and of course the need to share risk. That third-party payment disengages the payoff from and that's the real uncertainty. We don't actually have a number to put out as bait in front of those investors at the end of the road.
And that's part of why the investors need to be compensated, I think, because they don't know what the hell the return is going to be relative to other markets. And that's why you see larger rate of return in publicly traded companies in this sector, I believe.
Well, I guess what I'm arguing is, did you just describe a pure social cost, a welfare loss due to the uncertainty of the pricing regime?
It raises the cost of capital, just as the corporate bond, right? He has to pay more than Treasury. It raises his cost of borrowing money, and if you have to compensate investors for a lot of risk, that raises your cost of raising money, essentially.
Fair enough, and would we lower that if we sort of answered the question that everyone has posed today about the value of those additional life years? Would that reduce the uncertainty and increase?
I think it's much more FDA, and this comes back to Greg's point a little bit. So we have a lot of development in post-surveillance. So FDA takes, as everyone knows, 10 years on average, 90% from IND to NDA. BLAs are not a little bit better. So if you're an investor and you look at that, and you have WhatsApp paying $17 billion in 3 years or 2 years, whatever it was, and you have a medical product that's going to pay with a 90% chance nothing, but if you get paid in 10 years, that's a pretty rough, generating rate of return on that kind of scenario is a little rough. So the real issue, I think, is how do we cut this 10-year approval process at FDA? And I think technological advances should basically cut that, because we're going to have a lot better post-market surveillance in the future. All this big data that's being developed essentially is going to allow us much quicker information distribution when things go wrong with a particular medical product. If we're much better at sort of catching when things go wrong, let's say the extreme case, one person dies whenever we have a problem with a side effect, only one person dies. It shouldn't take 10 years of testing to avoid that death in some sense. So you basically, by being better at post-market surveillance, you will alleviate the need to actually have pre-market testing in some sense. And I think that's the development that has to take place with new information technology. We are much quicker in getting stuff that's bad off the market than we used to be. It's going to be even more so in the future. But because of that, you don't need 10 years to make sure it doesn't happen. You might need 3 years or 4 years or whatever. But we can do a lot more things post-marketing as opposed to pre-marketing.
I just want to take a bit of a contrarian stance in that while this discussion, and particularly this, is around how do you make the markets function well to fuel biomedical innovation, and that is the topic of our talk today, we are engaged in a larger endeavor, which is, I would say, is life, liberty, and the pursuit of happiness and maximizing population health. So biomedical innovation does not exist in a vacuum. It exists against competing needs and competing innovations and efforts that can improve population health. So I want to put a larger frame around the conversation.
You only make profits if you improve health. I agree, totally.
So Tom, I want to respond to your example of decreasing the clinical development costs. And there's two ways that even FDA right now is looking at doing that. There are some proposals for more of a limited pathway for drug development. So if you narrow the indication, that might require less data for approval, just smaller sample sizes for the clinical trial. You still get the same evidentiary criteria, so we're not limiting the evidence that's needed for approval. So that's one way to do it. The other way is sort of this balance of pre-market and post-market data. And we have seen on the FDA side, especially for medical devices, although as we grow the opportunity to collect better data in the post-market setting, I think we'll see this on the drug side too. But with medical devices, very rich registries out there, and they've just recently been used to expand indications for devices using post-market registry data for a regulatory decision. So in that particular case, a new approval, the company did not have to go back through the full clinical development program. And as we get better with adopting electronic medical records, integrating them with claims data, and developing methods for how best to control for all the biases that we see in observational research, we can get more rigorous and get a better ability to get to causal inferences that might help reduce at least some of the data that's collected in the pre-market setting. If we can approve the drug and say, okay, as long as we have a safety net, once the drug is on the market, to really track in real time those safety events and to confirm benefit, then you're right. I think we can get to a more reduced expense for pre-market clinical development.
I wanted to get back a little bit to this credit market issue, which has been raised by others before this panel and myself as well. So suppose Sovaldi worked in the following way. You had to take it every year, but it only cost $3,000 a year to take it. We wouldn't be sitting up here, I assume, debating whether that was useful or not in terms of a therapy. So the fact that you have to take it all up front and basically the shock of having the large prevalence is about 200 times incidence for Hep C, roughly. So you have a big stock of people who are going to rush and get treatment. Not everyone, obviously, but much bigger than the flow of patients who are going to come in the future getting treatment. Especially if we reduce that stock, it's going to be even less of a flow, as Dana demonstrated. So how much of this is a credit market issue as opposed to a value issue of Sovaldi? Because I think everyone agrees if it was $3,000 a year for a therapy that eliminated Hep C in your body, no one on this panel, I assume, would think that would be a bad or a very expensive treatment. Or maybe you do. I don't know.
I think you're the way you're posing it ignores what Sam Nussbaum was talking about, which is there's got to be an overall value proposition here in terms of how much we pay for health. I mean, spreading the cost doesn't deal with the essential question, which is how much more than $20,000 a year can a family making $50,000 a year spend on health care? Whether that and if we're gonna put health care in the same mortgage box as people's homes, I mean, you're going to run out of money. I mean, you can talk about risk capital till you're blue in the face. There is a natural cap somewhere on how much we can spend on health care, and that pie has to be divided in some reasonable way between all the providers and all the people who are taking risk in the system. What you seem to be suggesting is that we can just pay infinitely, just spread the cost. That doesn't make any sense to me.
Well, did you pay up front? Well, you made it maybe paid up front for your house, but most people don't. and I think a lot of times the fact that you have high initial costs, people prefer to pay it over time because they can't pay the $1 million house up front.
You know, a pragmatic issue is that states, don't tend to do this, be it legal or constitutional question in a lot of states whether they could actually amortize, the future cost of a drug and in the way that you're suggesting. Politically, I think it would be a very difficult sell, to pay ahead or to spread it out. For the I have a sort of quantitative question here. You buy a house once, there's just one house, and you spread that cost out. These low-income individuals that we're curing of Hep C, what about what will they get next, right? If the true cause here, underlying cause, is a social determinant, it's probably going to determine something else down the line. I don't know if these sort of net present values have been adjusted for how many times we might end up buying the same house. I don't think I could convince local, state legislators to get into that business.
And they will ask, how big a house can we afford?
Absolutely, which we haven't ever,
right. And
we've never answered that question.
But we agreed there would be less houses bought without mortgages. Okay.
We learned that the hard way.
But I think also in general in Medicaid, I think debt financing through Medicaid programs, I think for an infectious disease such as Hep C makes a lot of sense. Why? Because the negatives are paying the price for the eradication program that Dana was talking about. And if the negatives are the ones that are not going to show up in the incidence of the future disease, they're benefiting. They're not paying Gilead anything, but they're benefiting in health. And a debt-financed program on the state level would essentially allow future beneficiaries of an eradication program to pay for the benefit of the eradication. And with that, I guess we have to end and go to lunch. Thank you very much to the panel.